it plays vital role in many things: movement, language, cognition. Okay, so the cerebellum is the structure here, okay, behind here. For those first time here, the cerebellum is the one that lie below the tentorium. This one called tentorium, the dura layer. A piece of dura matter. This is a dura layer. And below it, you have right cerebellum and you have left cerebellum. So you always have two, right and left. Same as the cerebrum, you have right hemisphere and left hemisphere of the cerebrum. Okay? Always two. So, looking at the cerebellum, you see here the structure which consists inside the cerebellum. You can divide that accordingly. Okay. You can divide like here. Okay. Maybe this one the best picture for you to show it. Okay, this one. This division of the cerebellum, you have midline, vermis, and the lateral part, you call it hemisphere of the cerebellum. Okay? Same as the cerebrum above. Cerebrum, you have right hemisphere and left hemisphere, and the midline, you call it corpus callosum. But for the cerebellum, it's called vermis. The structure called vermis. Interestingly, cerebellum also has another lobe behind here. You call it flocculonodular lobe. Okay? Imagine you make the cerebellum flattened out. Flattened out so that you can see the surface of the cerebellum. Actually, the cerebellum is like this. Okay, these are the features of the cerebellum. The first image show the ventral view. The ventral means anterior or front. Ventral, anterior, front view. And this the midline or the lateral view. You see from the side. Okay. The word may be confusing for you. The anterior is the front, the posterior is behind, the inferior is below, the superior is above. That's an anatomical term. Okay. Other term for direction is a rostral and caudal. Rostral mean toward the head, caudal mean toward the tail. Basically, rostral, head side and tail side. Caudal is the tail side. Okay, like spinal cord, brainstem. So they have rostral and caudal. Cerebrum as well. The rostral part is the frontal lobe. The caudal part is the occipital lobe. Okay, or the anterior part of the cerebrum is the frontal lobe. The posterior part is the occipital lobe. Okay, rostral caudal. Another one is a ventral dorsal. That's another term you heard in anatomy, ventral and dorsal. Ventral refer to the anterior part, dorsal, posterior part. Okay. But it's different when you look at the brainstem and the cerebrum or cerebellum. It's different. Why? For the brainstem or spinal cord or the cerebellum, the ventral is the anterior part, the dorsal is the posterior part. But when referred to the cerebrum, okay, the one above, the big one, frontal lobe, temporal parietal lobe, the ventral is inferior part, the bottom one, the lower view. And the dorsal is the surface view. So the ventral is inferior view, the dorsal is the superior view. But for the brainstem, cerebellum, the ventral is the anterior view and the dorsal is the posterior view, which is contradict to the cerebrum. Why? Why so? Because of the bending of the cerebrum and the brainstem. If you look at the brain, it's bending at the brainstem and the cerebrum. So it's like this, bending. I'll show you later on, it's bending. It's a picture here, the whole brain. all about cerebellum. I just introduce you the term here, maybe here. You can see here, this is the ventral, this is the dorsal, but for the cerebrum, this is the ventral, and this is the dorsal, because the bending, this is straight, vertical, this is horizontal axis. So because of the bending, the cerebrum is bending on the brainstem. So the ventral is inferior, and the dorsal is superior. But for the spinal cord, brainstem, the ventral is anterior, the dorsal is posterior. Why the term shift? Because of the bending of the central nervous system. Why is bending? Why the central nervous system is bending? Because of the buoyancy. Buoyancy is following the Archimedes principle. The brain full with fat and water. So once inside the CSF fluid, even though it's minimal fluid, CSF, but the brain, because of fat, they tend to be bending. So same when you get pregnant, so you have amniotic fluid, a lot of fluid inside your tummy for the pregnant woman. The purpose of that fluid is to create buoyancy, Archimedes principle. So the buoyancy, that means floating, floating. Just like when you walk into the swimming pool, you cannot walk vertically. You have to be horizontal because of the water, right? So when you walk into the swimming pool, you walk vertically, and then once the water is become higher and deeper, then you tend to be in the horizontal posture because of the buoyancy. You see? So same as the central nervous system. Because of the buoyancy, the posture is bending. Just like Ferrari driver, the F1 driver, they have to be bending. We call it microgravity posture. When you go to the outer space, your posture become bending. You are bending. But when you on Earth, because of the gravity, so we call it gravity posture, so you are vertical. Like you are vertical. With two legs and then vertical. But the animal, they are microgravity. They are bending, all animal. With 4 foot, no foot, they all horizontal. But the human, only human is vertical. Interesting. So suggest animal coming from the microgravity. Yeah. Okay, that's the basic principle of the terms. Okay, looking back at the cerebellum. Can you hear me? Hello?
Yes, Prof.
Okay.
Yes, Prof.
Yeah. So far, any question? Ventral, dorsal, anterior, posterior, okay? If you read the book, you come across that term, anterior, posterior, ventral, dorsal, rostral, caudal. Okay, now we shift to the cerebellum. Cerebellum, as I said, you can divide this way. This division. Okay, you have vermis at the center hemisphere, the lateral part. So, and then you see the primary fissure. Fissure, I mean the groove. The groove, a bit of groove here, a bit of groove here, and here as well, fissure. So then you can see the separation between the lobes or the area of the cerebellum. So basically, the transverse division, anterior lobe, the posterior lobe, the folliculonodular lobe. It's a transverse division, horizontal. Longitudinal is a vertical division. You can divide this way. It's a vertical. So you have vermian, you have paravermian, you have hemispheric. So here, like vermian, paravermian, and hemispheric cerebellum. So that's longitudinal division. So you can divide this way, longitudinal, or you can divide horizontal. Okay. So it depends on you. When you're talking about something, you're talking about transverse division maybe. If you talk something else, you're talking about the longitudinal division. So basically, division is easy for you to understand certain things. That's all. It's a systematic way to divide the cerebellar lobe. Okay. This is a general description about the cerebellum. So again, the cerebellum, the brain consists of 2 things. You have cortex and you have white matter. So basically, the white matter is the track, the highway. Just like when you go from Kota Baru to KL. So Kota Baru and KL is the node or the end destination. So basically they apply to the cortex. And the highway connecting Kota Baru and Kuala Lumpur is the white matter. The white matter. So the white matter consists of, if you can imagine, is an axon, the long axon. And the cortex basically is the cellular body of the axon. So cellular body lie in the cortex. But interestingly, they got to create the cortex, such a very thin cortex. You know, the thickness of the cortex is about 3 to 5 millimeters, 3 to 5 millimeters only. And they're doing all sort of function. Okay, if you flatten out the gyri and groove sulci, then the area of the brain is more than the football field. Okay, and one area of the cortex, for example, 4 millimeters area consists of more than 60,000 axons, cellular bodies, more than 60,000. So if you imagine one small area, 4 millimeters only of the cortex consists of 60,000 axons, so you can imagine the synapse consists of 40,000 synapses. So you can imagine just area 4 millimeters, the area is so dense with the nerve and glia supporting cells. So the function are very, very complex. Okay. Talking about the cerebellum beside the cortex white matter, then again you have the deep one, the deep structure called nuclei. So it behaves like cortex again. It's a grey matter. So cortex is grey matter. The deep nuclei also grey matter. So basically they have the cell bodies inside there. So the axon come up from there, from the white matter. So the deep nuclei is, you can imagine such cortex as well. Okay. So what are those deep cerebellar nuclei? So you have four. The four important nuclei. So look at the nuclei here now. Shift to the nuclei. So you have fastigia here, fastigia, nucleus interpositus, globus nucleus, embryoniform nucleus, and then you have dentate nucleus. So 1, 2, 3, and 4. So nucleus interpositus consists of 2, right? So basically 4. If you can imagine here the picture here. So this is a midline, this is a lateral. Lateral means outside. Midline going to the midline, tengah-tengah midline. So you have 1, 2, 3, 4. The direction is, the dentate is the outward one. The dentate has such a big nucleus in the cerebellum. So dentate play a big role in movement. Okay, and 3, 2, and 1. So you have fastigia, globus, embryoniform nucleus. 1, 2, 3, 4. That's the nucleus. So this nucleus have connection with the cortex of the cerebellum, and also they have connection with to the outside of the cerebellum, to the motor area, to the brainstem. Okay, so that's called the input and output. Okay, before we shift to other area, now we look at the cortex itself. The cerebellar cortex is different from the cerebral cortex. The cerebrum. Cerebrum, you have 6 layers, but here you have 3 layers. Okay, some people call it the thalamus as the 7th layer. The thalamus has the 7 layers. So they include the thalamus, then include 7 layers. So the cerebellar cortex are different from the cerebral cortex because it has 3 layers: molecular layer, Purkinje cell layer, and granular layer. So you look at the histology slide here. So you have molecular, Purkinje, and granular layer. So molecular quite thick, Purkinje because they have Purkinje cell, the intermediate area here, and the deep one is a granular layer. So why granular? Because the appearance on histology is granular. It's granular. It's granular. So what consists in the granule layer? So all these granule-like cells. So granule cell, Golgi cell, the GG, all the GG. And then the Purkinje cell layer, why you call it Purkinje? Because it has Purkinje cell. It's a Purkinje cell. The molecular layer, then you have these stellate cells and basket cells. So you have 3 layers, okay? Nearly same as the hippocampus. Hippocampus. So you have you not have 6 layers in the cortex of the cerebellum, but hippocampus you have also 2, 3 layers. So this is cerebellar cortex, molecular layer, all this cell, stellate, basket, and the GABA, the neurochemical here, the taurine. Okay. The Purkinje cell layer mostly have GABA. GABA mainly inhibitory. Okay. In the Purkinje cell layer. Sometimes you have Bergman glia cell. So, but the important one is the Purkinje cell layer. And then deeper you have granular layer. So you have granule cell. Okay. People, it's stated here as 50 billion of them. Okay. Then you have GABA as neurotransmitter inside there. And for Golgi cell, for granular cell, you have excitatory glutamic acid. So this GABA and glutamic acid play in the granular layer. Some stimulatory, some excitatory, positive, negative. Always to stimulate, inhibit, day and night, male and female, pair, always in pair. So you have here basket, here showing the detail again. The outer cortex, very thin, about 3 mm. So this you have the molecular layer, the protein cell layer, and the inner granular cell layer. Okay, it's a drawing, anatomical drawing. Granular cell layer, protein cell layer, molecular layer, and all the exon. There you have cell body. Same picture, but here they mention about the climbing cell, the mossy fiber, or this is a type of white matter fiber that go up and down. The highway, the track that connect between the nucleus, the embryoniform nucleus, globus nucleus to the cortex. So you have white matter track fibers. Some people call it fibers. Okay, simple way to remember this one, simple way probably, all exon projecting up are excitatory, all exon projecting downward are inhibitory. So like this one that going up, all stimulatory, the one that going down, the nucleus, all inhibitory. Going up, all stimulatory, and going down, all inhibitory. So that's it. And the one that come out from the nucleus, all excitatory. Stimulatory, excitatory. The general rule. Okay? So if you go deeper to how the cerebellum looks like, some people divide into lobe, anterior lobe, middle or posterior lobe, and flocculonodular lobe. But some people divide further. They look into lobule, small lobule here, small lobule. You have blue, you have pink one, yellow, multiple, 3, 5 more lobule here. Yes, smaller than look, we call it lobule. Okay, when you look at the cerebellum, so the development of the embryology or the formation of the cerebellum itself can be divided into 3. Archicerebellum, that's the old, you can say in most animal, vertebrate animal. The paleocerebellum is the intermediate, and the neocerebellum normally exists in higher animal and also in mammals, in human. But the classic, the old one, in certain animal only and present in human, it's the archicerebellum here. The pink color, lingular and flocculonodular lobe. So this is the historical or classic or the old archicerebellum. So archicerebellum is part of the vestibulocerebellum to do with the balance. So that's why it exists even in the lower animal, because the lower animal need balance. Okay, they need balance. Probably they don't need this new cerebellum, the cognitive one, not really much important for them. But the lower animal probably they need this vestibulocerebellum. That's why they have it. Okay. Looking at the archicerebellum, the old one. So the flocculonodular lobe to do with the balance. Why? Because they have connection with the vestibular area or vestibular nucleus in the brainstem. They have connection there. Okay. So it receives input from the vestibular apparatus through the inferior cerebellar peduncle. So the brainstem has 3 peduncle. Peduncle, that means the area that go in and out from the cerebellum. So look at the picture here. There's a 3 peduncle. Okay, the superior cerebellar peduncle here, and this one the middle cerebellar peduncle, and the inferior cerebellar peduncle. Peduncle means like a bridge, a substance bridge, connect the cerebellum with something else. So you have 3 connections with the pons, with the midbrain. Okay, so you have 3 bridges there. The inferior cerebellar peduncle, interestingly, can be divided further into 2 or 3, like restiform body, juxta-restiform body, vestigia, fasciculus. Okay, that's part of the inferior cerebellar peduncle. Don't get confused. So it's It's part of it. It's a subunit of it. Okay, then go back to the previous slide. Arcus cerebellum, okay, its connection with the vestibular area to do with the balance. And because of balance, you need gaze, you need vision, so it has connection with the gaze center. Gaze center, that means vision. So vision important for you to be in balance. So the gaze center has in the brainstem, midbrain, also has in the pons, also has in the frontal lobe, the gaze center. And the second or intermediate is the vermis, the paleocerebellum, the intermediate in terms of phylogenetic or in terms of development embryology, the vermis. Some animal do have, some animal don't. Okay. So the vermis or spinocerebellum, the vermis line midline. Okay, it's a line midline. Basically, the main input-output is through the spinocerebellum. It's going to the spine, not the spinal cord. Lower down. You have spinal cord lower down. In your vertebral bodies, you have spinal cord. So the cerebellum connection to the spinal cord is through this vermis or spinocerebellum. Okay. What's the function of it? They influence the muscle tone, the posture, the muscle tone, the posture in your limbs, in your trunks, everywhere. So it's control your muscle tone. Okay, this is talking about the input and output to the spinal cerebellum. For the muscle, as I said, muscle, of course, inside the muscle you have proprioception. Proprioception, that means receptor that able to recognize whether you are in balance or not. The muscle and joint, whether they are fully in stretch or they are in relaxed. So they call it proprioceptive receptors. So this has input to the cerebellum through the spinocerebellum. So they enter the cerebellum through the inferior peduncle and superior peduncle, both. They can enter through the inferior or superior peduncle. And normally they terminate or end up at the vermis and paravermis. Vermis midline, paravermis is paramedian, lateral to the midline a bit. The most lateral is hemisphere. So this is called longitudinal division, okay, or vertical division. The major output are to the spinal cord or spinal motor system again, okay, through the brainstem. The neocerebellum is the latest in terms of development. So it has cognitive function. So it has connection with the frontal lobe, parietal lobe, and even in the nuclei inside the cerebrum, the basal ganglia. So the neocerebellum is the one that lie lateral, cover the hemisphere of the cerebellum. Okay, it's all everything except the unshaded, area. Talking about the vermis and the follicular lobe. The rest are neocerebellum. So they have vast input and output. They have vast function because of cognition. They deal with planning. And the precision of the movement, execution of the movement must be precise. Okay, language and so on, emotion maybe. So a lot of research still going on in the cerebellum. Not much know what's the actual function. They have more, probably more to it. We know little still about the brain. The neocerebellum is a new one. So as I said, they have connection to other area, even to the motor cortex. You see here the motor cortex. They have input from the pontine nuclei, from higher up go to the pontine nuclei. Then they have output to the brainstem area, corticobulbar tract. This one, corticobulbar tract. Bulbar means brainstem, cortex to the brainstem, bulbar. So the connections for the cerebellum, we can summarize as here. So vestibulocerebellum or the Arcus cerebellum or the classic one, follicular lobe, to do with the balance. You see the semicircular canal in the ear, the vestibular nucleus in the brainstem, the folliculonodular lobe in the cerebellum, the vestigial nucleus is part of the nucleus of the cerebellum, the most medial one. So all this deal with the balance. And the second or intermediate group, or intermediate in terms of development, is the vermis, and they have connection with the, as I said before, it's a summary, connection with the spine, or with the muscle, all your muscles in your body. So they make sure the muscle acting properly, contract properly, relax properly. So this is the spinal cerebellum. So where's the nucleus coming from? It's an interpose nucleus that has two embryoniform nucleus, and another one. So you have F, E, and then dentate nucleus. So interpose nucleus, and then connect with the spinal cord. The cerebrocerebellum is the latest one. So they have connection with all with the motor cortex. They have connection with the part of the certain lobes, frontal lobe especially, and the limbic lobe as well, the parietal lobe or the cingulate gyrus. Okay, and they have connection with even with the basal ganglia, the putamen caudate nucleus. Okay, the basal ganglia is the initiation of the movement, but cerebella is the precision of the movement. So the components of the brainstem and diencephalon related to the cerebellum. Okay, this is the summary again. So the summary of this statement. So we can see here connection to the cortex of the cerebrum, the motor cortex, even to the frontal lobe, not drawn here. Then connection with the brainstem. So this is the pontine nuclei, with the inferior olive, the dorsal nucleus of Clark, to do the spinal cord, this one for vestibular nuclei for balance, and this inferior olive and pontine nuclei coming from above. And they have connection to the motor cortex, and in between they stop at the thalamus. The thalamus is the place for them to have a connection or intermediate connection in the thalamus. So some sort of intermediate place, or intermediate nodes, or intermediate nuclei, or intermediate structure before going to the cortex of the cerebrum. So, functional organization of the input to the cerebellum. Okay. So this is a summary again for you, probably from the frontal going to the pons and going to the cerebellum. This is the input. And some input coming from this area. This is the input. Inferior olive, spinal cord, vestibular nucleus. How about the outputs? The output also involves some same structure like inferior olive. Also they have output. This is the output mainly going through the superior cerebellar peduncle, mainly going to the motor cortex. This is the output one. And most going through the thalamus. Which part of the thalamus? The ventrolateral part of the thalamus. The ventrolateral is named as the nucleus of the thalamus. So the thalamus has many nucleus, many small areas. So the area responsible responsible in connecting the cerebellum with the higher function is the ventrolateral part of the nucleus. Okay, you have many nucleus inside the thalamus. And some of the fibers that go through the superior peduncle, remember they have middle peduncle, inferior peduncle, and superior cerebellar peduncle. So the superior cerebellar peduncle mainly are the efferent or the output, efferent. Efferent is the input, say efferent. So the A input, the E output. So some fibers have connection to the red nucleus in the midbrain. So this is such a giant big nucleus in the midbrain, red nucleus. And it plays important role in many things. Red nucleus. And then from there it's connected with the inferior olive and so on. So this is the summary for the output. There's now input, but now output. The summary of it. So lateral hemisphere, the one that the major nuclei that responsible for lateral hemisphere output is the dentate nucleus. And then the output information, energy, power, wave, going through the superior cerebellar peduncle. Okay? The action potential, whatever, is traveled through the superior cerebellar peduncle. And then it's target to the, as I said, some stop at the thalamus, some even go further up, high up to the cortex, motor area and frontal lobe and so on. And some pass to the red nucleus. Intermediate, interpose nuclei, vermis, vestigial nuclei. As I said, this is the name of the peduncle, part of the inferior cerebellar peduncle, uncinate fasciculus just the restiform body is just only part of the inferior cerebellar peduncle. So it's a subcomponent of the inferior cerebellar peduncle. So where the output end up, they are end up here in the tectum ventrolateral. That means it's a nucleus of the thalamus. Where's the tectum? Tectum is the inside the midbrain, near the aqueduct. The one that control your eye movement, your hearing, whether you hear or not. The tectum, you have superior colliculus, inferior colliculus. So the structure inside the tectum is the superior colliculus, inferior colliculus. The one that behind the tegmentum of the midbrain. So you call it tectum. Okay. Maybe I got picture here. So you can see here, this is the tectum, this is the tegmentum. The tectum consists of superior colliculus and inferior colliculus. It lies close to the pineal body here. It's the pineal gland. Okay, that's why if tumor here, something here compressed on the tectum, so the tectum function is for the outward gaze, the eye looking outward, so the patient cannot look up. There's a restriction in looking up because the pineal gland compressed on the tectum. So if you have lesion tumor in the cerebellum, what happens? As I said before, it's control the muscle movement, patient become unsteady, the patient become imbalanced because of the vestibular output. Connection with the ear gone. And maybe patient become imprecise in movement, okay? And also have maybe emotion behavior, cognitive impairment because of the cerebral hemisphere connection with the frontal lobe, the secondary and so on. Okay? So this is the summary for the input. There's now output. This is the input. You can read on your own. The one I described to you before. Input and output. So this is the input one. The input pathway, the spinal cord, the vestibular area, and from the higher, the cortex, through the pons. Normally, the higher one, they go through the pons. They go through the brainstem. Before end up in the cerebellum, they go through the pons. So which part of the pons is a pon that having the nuclei called pontine nuclei. So this pontine nuclei travel through the middle cerebral peduncle, and then they end up in the cerebellum. So this is the efferent, the input. The spine one, the spinal cord, so normally they go through the inferior cerebellar peduncle and some go through the superior cerebellar peduncle. So it depends on whether you are upper limb or lower limbs, okay? And then the climbing fibers, most of them go through the inferior cerebellar peduncle. Red nucleus, cortex, okay, the vestibular going through the inferior cerebellar peduncle. That's the restiform body, part of the inferior cerebellar peduncle. Okay, it's just show the diagram. Functional region. Now the functional region of the cerebellum, as I said, you have lateral, intermediate, and midline. Okay, the vermis is midline, and the other one is a flocculonodular lobe. Okay, sometimes people just combine the intermediate hemisphere and the lateral hemisphere as one hemisphere. Okay. But here they divide further the lateral hemisphere to the intermediate hemisphere or paravimian. Some people call it paravimian. I told you before, it's a paramedium, same as intermediate. So this is the blood supply. Look at the blood supply of the cerebellum. Mainly they come from the basilar artery here. The big artery from the front of the brainstem. So this is called superior cerebellar artery. So this is called anterior inferior cerebellar artery or ICA, and this one is the posterior inferior cerebellar artery called PICA. So if you have clot or thrombosis or blockage at the PICA, then you have stroke of this area here. So if the area of the stroke involves the brainstem, the medulla here, so you have both sides of the cerebellar side and also the medulla side. Okay. So if you have stroke in ICA here, so this area here affected, mainly the dentate nucleus and so on, then you cannot move properly the limbs. Okay? This again show the summary of the blood supply. So what's the function in general? So the function of the cerebellum to provide precision in timing, precision in movement, appropriate patterns of contraction of the muscle. So basically, precision. And another one to make sure the movement are coordinated movement. a smooth coordinated movement. Okay. All this occurs subconsciously. That means you cannot control it. Okay. Just like your heart rate, you cannot control it. You cannot stop your heart rate. Okay. Breathing, automatic. You can stop for a while, but then it has to be continued. Not you die. So this called no control over it. Okay. So you're not aware of it. So remember, precision and smooth coordinated movement. So what happens if you have lesion, infarct or stroke or tumor there? So all this impact. The precision of movement impaired, the movement is not smooth, it's coarse, kasar, coarse, and then incoordinated. It's not well coordinated, so the movement is coarse. So when you ask the patient to touch something, the hands move awkwardly, touching something that beyond the area or side of the area, so it's not precise. Okay, so this is the map of the area of the limbs and trunks according to the cerebellar region that we described just now. So you look at the image here, basically it tells that the appendages or the limbs or the upper limb or lower limbs lie more lateral, and the trunk lie midline. So what it tells, the summary of it, the lesion, midline lesion, normally the patient has truncal ataxia. Truncal ataxia, that means the body is not imbalanced. So if you ask the patient to stand up or to sit up from the lying position without using the hand to support, then the patient unable to do so. It becomes imbalanced. It moving right, left, off the trunk, not limbs, the trunk. Okay. How to test it? The way to test it, ask the patient to sit up from the lying position without using hand support. That's the test for truncal ataxia. Okay, if the lesion more lateral, not midline, but more lateral, okay, so it might catch the appendages, the limbs, so the upper limb or lower limb. So the upper limb may be impaired, more impaired than the trunk. Trunk, that means the central part of the body, the thorax, all those, the abdomen, the midline. So if the lesion more lateral, like commonly happen, is more lateral, the tumor most of the arising from the lateral part, then the hands, the problem starts with the hand first. And then if the tumor getting bigger and bigger, so it might include both, the midline as well. So the patient have both truncal ataxia and limbs ataxia, or imprecision in movement for the limbs. This is the summary of it. Okay, if the lesion involving the flocculonodular lobe, then obviously it's affect the vestibular area, the balance, becoming more unbalanced. Okay. It's now ataxia, the limb, coordination of the movement, but involve the flocculonodular lobe or the fibers or the connection, then you have imbalance, which is normally happen. What happens in patients with a big, huge tumor? Okay. So far, okay? Any problem? Any question? Hello?
Okay, Prof. Prof, would you be providing us?
Okay, Prof.
Okay, any question?
Would you be providing us the notes?
Oh, this one, you can ask my secretary to email to you all.
Okay.
Maybe after this, I ask my secretary, or tomorrow I ask my secretary to send it to you all.
Okay, thank you, Prof.
Good afternoon, Professor. I would like to know a little bit more. I mean, we passed already, but I'm still couldn't catch that part. The blood supply. The blood
supply.
Yes.
Okay. We go back to the image.
I'm so sorry for that.
Blood supply. Maybe you
Yeah.
the blood supply here.
Yes.
So The blood supply for the brain, you have vertebral arteries here, vertebral artery coming through your spine, cervical spine. Okay, inside the cervical spine, there's a hole where the vertebral artery travel from the heart. Okay, it's going both right and left side. It's a right and left side inside the spine. Okay, another one is the internal carotid artery. Internal carotid artery supply mainly the cerebrum above here. So internal cerebral artery, they're going through the certain foramen or opening in the skull, and the internal carotid artery gradually divided into middle cerebral artery, anterior cerebral artery. Okay, and they supply the cerebrum, the frontal lobe, temporal parietal lobe. Okay, but for the vertebral artery, is from the right and left is joined in front of the medulla. In front of the medulla, okay, from the basilar artery. If you look in the Google, whatever, you can look for the basilar artery. So it's basilar artery is basically the result from the joining from the vertebra right and left combined on the basilar artery. So this basilar artery is a huge artery, very important artery. It lies in front of the brainstem. Okay, it lies in front of the brainstem. So behind the clivus, the bone, the clivus, the bone is a clivus, and it's in front of the brainstem, basilar artery. Okay, so in front of the basilar artery is clivus. Behind the basilar artery is the brainstem. Okay. Alright. Hold on. Somebody want to ask to sign. Ringkas jalan. Okay. Okay, so basilar artery in front of the brainstem, and its branches. Its branches. For the vein, we call it tributaries. Branches for the vein, tributaries. For the artery, we call it branches. Okay, so the branch of the artery, you have superior cerebellar artery. The uppermost is superior cerebellar artery. Why superior cerebellar? Superior means above. Cerebella is cerebella. So they supply the above, the uppermost part of the cerebellum. But that's why we call it superior cerebellar artery. So when it doing so, it travels a bit of the part of the midbrain and pons. So it gives some branches to the brainstem as well. Okay. Another branch is ICA. We call it anterior inferior cerebellar artery. So anterior front, inferior below. So anterior inferior cerebellar artery. So it supplies the anterior part and a bit of inferior part of the cerebellum. Okay, that's why I call ICA. Same, it's got some branches supplied to the brainstem as well. What it travels through. Okay, another branch, which is not in a direct branch from basilar, but it's normally a branch of the vertebral artery itself. So we call it pica. Pica is a term, it's a posterior inferior. That means the posterior part of the cerebellum and the inferior part of the cerebellum supplied by this artery, pica. If you want to go into detail, we have segment. All these have segment. Segment 1, segment 2, segment 3, segment 4. They divide to segment. So that one maybe not important for you. So segment 1 supply the brainstem, segment 2 supply this area here, segment 3 supply more like this area here. So pica, ICA, and SCA. Okay. So once they go inside the cerebellum, then you have more detail, like small, from artery become arteriole, from arteriole become capillaries, from capillaries they form the venule, and then from venule they form the veins, and veins become sinuses. So they drain to the sinuses. Okay, the veins, maybe here's the superior cerebellar vein, and then drain to the vein of Galen, and then from then it's drained into the superior sagittal sinus. Okay, from the arterio capillaries, and then from the capillaries there's exchange of the oxygen, nutrition, and so on, and then absorbed to the venule, vein side. Now we're talking about vein side, and then venule, and then veins, and then after vein you have sinuses. Okay, that's the flow for the blood supply.
Professor, is that if anything happens in that blood supply, so you got unconsciousness, is that the one sometimes happen for example, for the football player, when they head badly. Is that one of the causes that is affecting?
True. So true. Yes. So if you have blockage in the artery, so you have all the symptoms. So the symptoms and sign basically depends on the blood supply. So if the blood supply in the area of the hand, so you have hand weakness because there's no oxygen nutrition to the area. If the blood supply to the area of that there with consciousness, I'm talking about consciousness later on.
Yes.
So if that blood supply in the area of consciousness deal with consciousness, then you have altered level of consciousness. So it depends on the supply area or the functional area of it.
Okay. Yeah. Thank you.
Okay, this is the cerebellum. I think I finished on the cerebellum. Maybe a bit more. This is a show picture of ataxia. Ataxia, that means imbalance. If you ask the patient to lift up one leg, then they cannot do so. Walk on a straight line, so cannot do so. You can walk on a straight line. That means toe to heel, heel to toe, you can do it. But patient with cerebellar lesion, they cannot do it. Okay, as I said, cerebellum has neuropsychiatry as well. It's been studied nowadays. Lately, it shows that cerebellum is not just only motor sensory. It's not just only balance. So it shows, as I said before, it's to do with the emotion as well. So some study shows some emotional function as well. Okay, for example, here the posterior cerebellum, the one that behind, obsessive thinking, compulsive behavior. Also, even flocculonodular lobe, it's not just only balance. So it's to do with blunting, emotion, appetite. If you have depression, so this area also altered, disturbed, abnormal. So it's complex. But the main one, the major one that we have known, those to control the movement, the balance, the precision, the coordination movement. But behavior part, we still not really know much. But it shows that cerebellum also deal with all these functions. Okay, the summary behavior also. Cerebellum also have behavior and language. So this.
Prof.
Yeah. Yes.
Prof. Okay. Just now you showed us the.
Hello. I cannot hear you. Hello? Hello?
For example,
Cannot hear. I cannot hear you.
Hello?
I cannot hear you.
Okay. Can hear?
Okay.
Prof, just now you have mentioned about the for example like depression. So if the client having the problem in depression, and then after a few years she can treat it from the illness. So is it means that the brain part of the of the client also treated well?
Yeah. So depends on the network of the depression. So if the depression fully healed, the network back to normal. If partially healed or maybe 30% healed, so some network still abnormal, some network still abnormal, and some network becoming normal. So depends on the degree of healing.
Okay. Prof, how about, okay, for example, if the just now you explained about the this basilar artery. Okay, if for example, the client who have the asthma attack or problem in respiratory, if they are neglected the problem at that time, is this possible lead to the death?
Not clear. Say it again.
For example, for the patient who have asthma attack, that condition can lead death, kematian. But is that related with the blood processing in the brain?
The asthma one to do with the chest, lung. So the lung doesn't work properly because of the constriction, asthma, constriction of the lung airway. So because of that, the oxygen inside the blood is lacking, reduced, kurang, lack of oxygen. So because of lack of oxygen in the blood, so the brain has not enough blood, has not enough oxygen. Okay? So because of that, you become unconscious because of lack of oxygen to the blood.
Oh, okay. Thank you, Prof.
So the main problem is at the lung, and the secondary effect is at the brain or other organ as well. Okay.
Okay. Thank you, Prof.
Okay. So look at the picture here. It just shows the network. Even in autism, the study shows the cerebellum also involved. Even in schizophrenia, the cerebellum also involved. I show here the study, the latest study done. Okay, that's the cerebellum. So we finish on time, 2 to 3, and next is the consciousness, right? 3 to 4, right? Hello?
Yes, Prof.
Okay. So any question? We still got time. Ada soalan? Siapa still have question or something in mind? Or wondering? Anything?
Is it possible to ask questions through email also, Professor?
Anything. You can ask anything.
Okay, thank you.
Okay. If no question, then we go to the consciousness. Consciousness is a big topic. Is a interesting topic, complex topics, and people still argue, debate, don't know what is consciousness. Even to define consciousness is not known. People still don't know what is consciousness, how to define it. Okay. For the medical doctor, consciousness, something to do with the brain. Okay. But for the physicists, for the some neuroscientists, they believe consciousness is not in the brain. The consciousness is cover the whole universe. That's interesting. Okay. So even basically, is what they say. Consciousness covering the brain and the universe. So the whole universe or cosmos is a consciousness. Okay, that's interesting theory. But I think it's from my reading, from my research, from my experience, I think probably they are right. Consciousness is not just only in the brain. Consciousness cover everywhere. Okay. First, probably need to define what is consciousness. So it depends on your definition. So as I said, some people define that way, some people define this way. So still, most disagree with one group of definition. But for medicine, for doctors, they define consciousness as a state where you are not alert. Okay, where you are alert, consciousness. Unconscious, that means you're not alert. So conscious, you are not alert. So I go detail after this. But anyway, for some, consciousness something to do with the energy, power. Energy is life. Life is energy. So consciousness is energy. So because of energy, you have living, you have life. Because of energy, you have form, physical form, matters. You have light, you have electricity, you have ATPs in the chemical, ATP, GTP, ADP, energy. All is energy. So some people define consciousness in broad way, energy. Okay. This topic I talk about consciousness and a bit of sleep as well because they are interrelated. And this is the second slide. Okay, the term consciousness from the Latin consciousness means with know or with knowledge. Okay, with know or with knowledge. So it can refer to a waking state or experience or possession of any mental state. So this waking state, experience, possession. So it's broad. It depends on your reading. If you read that article is defined that way. If you read other article, it's defined that way. But basically, the Latin word is a with known or with knowledge. Okay? Probably some of you here prefer my way. Consciousness is energy. Okay? Or some here probably has background of medicine, so consciousness is referred to the brain only. Okay? So some of you don't believe that the table also conscious. Okay?
Professor, can we also connect emotional intelligence with consciousness?
Emotional intelligence, everything, yes, everything under consciousness, under the sub component of consciousness. Everything. Everything. Even the memory. So you have to have the consciousness to memorize. Okay? So the question is, when you sleep, do you have consciousness or not when you sleep? That's another one. Okay? Whether you're conscious or not. So according to most definition, you're not conscious. You're sleeping. You're conscious like when you walk. When you walk, you have purpose, you're aware, you have element of awareness. Okay? And then some have epilepsy. They're not aware, but conscious, walking, but not aware of it. So when you ask the patient, why you go there? Then the patient say, oh, I'm not aware of it. But you look at the patient walk, look like conscious, but not aware of it. So that's, again, whether that to include.
Prof?
Yes?
Prof, how about sleepwalking? Are we conscious?
Same thing. So sleepwalking, are we conscious or not? So sleepwalking. So you sleep. Some people say you don't have consciousness, but when you walk, you have consciousness. So it's debated. So when you walk during sleep, that means it looks like you have consciousness, right? So according to I prefer like energy. So once you have energy, even when you sleep, your brain still have energy. That means you're still conscious. Maybe your consciousness degree is lower. The degreeness, the level is lower. So for me, I better define consciousness as energy. So for me, table also conscious because it has energy. Confused? This is a very interesting topic. I can finish it 1, 2, 3 days. I can finish it in 2, 3 days. It's a very interesting topic about consciousness. Why isotable have consciousness? You know why? The quantum physics. Have you heard the physics? Anybody know about quantum physics? What is quantum physics? Physics, the one that you learn in Form 5, Form 4, if you are science stream, you know about the physics. You throw the ball to the wall and the ball coming back to you. That's the physics. Okay? But for the quantum physics, if you throw the ball to the wall, it go past through the wall. It doesn't coming back to you. That's quantum physics. So what's the difference? The physics deal with the big object. The quantum physics deal with the smallest object, the quantum physics. So the physics at the smallest matters, smallest object, they not behave like a big object. So the small object do not follow the rules of the big object. That's interesting. So one of the rules, they have many interesting rules. You have superposition, you have tunneling, all this deal with the brainwave. If you do EEG, then you see this principle, the quantum physics principle, the brainwave. Okay? So one of the major principles of the quantum physics saying that an atom can be particle and at the same time can be the wave. Duality, day and night, male and female. An atom can be a particle or can be a wave at the same time. Confusing? So, because
Professor?
Yes?
Can I ask something? Does that mean that it relates to the classical debate of dualism and physicalism sort of things, sort of view?
Yes. Yeah, something like that. So dualism, duality, and so on. So, but interestingly, this duality also exists in physics, in quantum physics, because of this principle. So the duality concept also exists in physics, in scientific knowledge.
Right.
One of it is this one. The atom can exist as particle and wave. So if you look at the table, if you look at your friend, so they are matter, they are particle, matter, okay, particle. At the smallest, talking about the smallest level. So we're talking about the smallest level. Talking about, for example, brain. You have organ, brain. Below the organ, you have tissues, histology, tissues. Below the tissues, you have cell. Okay, cell, and you go deeper into the cell. You have molecule. The chemistry of it. If you go deeper to the molecule, you have atoms. Okay, all the atoms inside the molecule in chemistry. Then if you go deeper into the atom, now quantum physics. Deeper into atom, you have quark, you have proton, electron, and so on. Okay, so that's the quantum level. And if you go deeper, they call it deeper than the subatomic particle. Then you have wave. Okay, deeper than wave. What is deeper than wave? That's the question. In my opinion, it's light. For me, I think it's the infinite light, the first light. Okay, it seems that everything coming from the infinite light. The origin of everything is infinite light. So infinite light from the subatomic particles, the wave from the subatomic particles. Subatomic particle become the atom become the molecule become the cell become the tissue become organ. Okay, organ become human being. Object. See, you see, at the smallest level, at the deeper level, the deepest level is wave. So now you can imagine the table as you are now, and also you can imagine the table is the wave, and you can imagine your friends next to you is the wave. Just only wave up and down. So that's come the energy. Okay. If you go to the beach, you see the wave up and down, up, down, up, down. Everything is energy, up, down. So wave is energy, okay? And energy is something to do with up and down. Look at your heart rate. It's up, down. Your blood pressure is up, down. Your breathing is up, down. Everything is up, down. Tell me, everything is up, down. There's nothing up, 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 up. It's always up, down. You go up, 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 and then down. And then up, again, down. So this tell everything is energy. That comes the deeper one. You have a vibration, string theory, and so on in the universe, cosmos. So now what I'm trying to say now, it seems that everything is energy, right? Because of that principle, everything is energy. So that's energy. People call it field, one field, or one consciousness. So everything is a one field. So in psychiatry, you have abnormal thought, so abnormal delusion and so on, hallucination. So out of reality, fragmented reality. So the reality is fragmented, or basically your one field, one consciousness becomes fragmented. So that's the theory, the debate behind it. Is the psychiatric patient have this fragmented reality or fragmented consciousness or fragmented one field? One field talking about everything, whole wave, they are interconnected, everything. If you are here, you are in London, your friend in Mexico, everything connected because of vibration, because of wave. But because of your wave and your friend who is in Mexico are in coherence, then probably you're gonna marry her, you're gonna marry him, the one, because your wave are coherent. You are in tune. Okay, so it comes another principle in quantum physics. We call it entanglement. Entanglement, that means if you move your hand here, but your friend in New York, it moves as well without any connection. It's called entanglement because of the wave. Okay, that's interesting. You won't see the wave. That's another thing. You cannot see the wave. Okay, but you can see the particle. You cannot see the energy, but you cannot see the wave and energy. You cannot see the energy and wave. You can see the particle. That's interesting. So you can see the table, you can see the human, but you cannot see the energy and wave. Because your brain is tuned like that, it's been created like that. Your brain can see the 3D, can see the particle, can see the dimension in that way, but you cannot see beyond that dimension. Okay?
Professor, may I ask you one question regarding this energy and we can see the 3D. Is that this consciousness is same for every human brain, or is have some kind of variation?
Okay, so consciousness is a background energy. People say it's a background energy, so that means different. In terms of background energy is the same, but in terms of interaction with your brain is different. So that background energy, when you interact with the brain, so different because of your brain is not same as your friend brain, something like that. So that's the argument, debate behind it. But the energy they say is the same. One consciousness, one field. So because of the interaction with the brain, so it came out with a different result. So it's a different view. So some people view that way. The consciousness as a background, diffuse, cover the whole cosmology, and it's interact with the brain. So it resulted in A, B, C, and D, and E, and many more. Okay, one view.
How we can increase this interaction if that's the one who is affecting our consciousness?
Say again?
How we can increase this interaction, because you say background energy is the same, but the interaction with brain give us a different type of consciousness.
Yeah,
so how we can increase that so that we will more conscious everything we do?
Yeah, probably so. So when you are ill, your consciousness down. So you can start to take a medication to make your consciousness become higher, back to normal. So probably there's an optimal level. You have to compare with that optimal level. I don't know. So in terms of medicine, we look in that way. So everything is at the optimal level. But when you ill, you are down, then maybe your energy is low. So because you refer energy as consciousness, then your consciousness is low. So that's one thing. But for medicine, for medical doctor, they view different way. As I said before, for the doctors, brain is conscious. Brain is everything inside the brain. It's not in the energy. It's not in the cosmos. So the consciousness is inside the brain. So because of that view, so it's the same. Consciousness is inside the brain, and certain area of the brain has certain structure of the brain deal with consciousness. So if you inject that area, then your consciousness also altered, impact. Okay, that's one view, medical view. But same with the energy view. If you impact the anatomy, the area of the brain that deal with consciousness, of course, the interaction between the cosmos, your brain and cosmos energy is also altered. It's the same argument. Just you look at different perspective. I understand, a bit confusing. Eh? Okay.
Thank you. Yeah.
But it's a very deep, very interesting, very deep. So now still people feel so philosophical, so debating, and because nowadays the scientific knowledge try to jump into the metaphysical world. Metaphysics, something to do with soul, everything, energy. So basically, some people say life is soul, soul is life. So what is soul? Soul is energy. It's indirectly means it's analogy. It's just only analogy. So soul is something to do with the energy. So life is soul, soul is life, or energy is life, life is energy. It's just only analogy. Analogy. So now we move to consciousness. Okay, where in the brain deal with the consciousness? Okay, the picture here shows the brainstem, and second one the diencephalon. You know what's diencephalon? Diencephalon is the structure that line between the cerebral cortex or telencephalon. We call it cerebral cortex embryologically as telencephalon, and the brainstem. Some people call it myelencephalon, rhombencephalon. That one, the brainstem. So in between the brainstem and the cerebral cortex is the diencephalon. What consists of diencephalon? They are thalamus, hypothalamus, the basal ganglia, all the stuff. The mid structure, the mid nuclei between the brainstem and the cerebrum. Okay. So and the last one, the cerebrum, the whole cerebrum. Okay. So where's the consciousness? Where is the consciousness? Where is the structure there is the consciousness? Okay. So this is a picture shows I mentioned to you about the buoyancy, the Archimedes. The brainstem looks like nearly horizontal, but the cerebrum looks like nearly this one. The brainstem looks like vertical. The cerebrum looks like horizontal. So you see the angle, probably about 60 degree, 70 degree angle. The angulation between the brainstem and the cerebellum. So it's bending. Bending is we call it microgravity posture. So why is bending? Why is microgravity? Because of the buoyancy. So we call it like sujud position. Some people call it sujud position. If you are Muslim, Christian, or Jewish, then it's a bending position or sujud position. So this bending because of the buoyancy, because of the fluid. And despite of having minimal fluid, CSF, the brain still bending because of the fat. Most of them, they are fat. Most of the brain are mushy brain. Okay? So where's the area that deals with the consciousness? Interestingly, the one area that deep inside and near the bending area. This area here. The whole, not just on the color one. The color one is the hypothalamus. But I show it here, the whole area here. So if you injure the hypothalamus, you become unconscious. If you injure the thalamus, you become unconscious. If you injure the brainstem, you become unconscious. That's from the medical experience. Okay. For example, you have stroke in the thalamus. Then you come to the hospital, you are unconscious. Okay? So that's why doctors say that structure, this structure, those structure, there is consciousness. Okay. But for the physicists, for some neuroscientists, they view different way. They view as this structure interact with the universe, cosmos energy. So if you injure the thalamus, the interaction is impaired. And you have impaired consciousness. Of course, they say this deep structure are important, but they add on interaction. The interaction with the outside energy or the diffuse energy. So that's the different view. So that's why they say consciousness covers the whole cosmology. One field, one universe. But for the medical, they just focus here. This is the area of consciousness. If you impact here, impact. So according to the medicine, here. But for modern neuroscientists, they view it beyond the area here. So what does area again? I said the reticular system, part of the reticular system, the reticular brainstem, you have reticular system here, the mosaic-like. If you look at the mosaic, it's infinite structure-like. If you study the book of infinity, the structure of the infinity looks like hippocampus, looks like thalamus, looks like mosaic, everything, look like chordate nucleus is an infinity shape. I think all the body, all the brain structure are infinity shape. In fact, if you look all around you, everything infinity shape. I'll show you later on the proof. If you go out, look at the tree, they are infinity shape. That's another interesting. I publish a lot on this. You are confused? Hello?
No, very interested.
It's very interesting. Very interesting.
Yeah.
You do research on this stuff, we can join you.
So look here at the deep structure here, the structure that deals with everything. So if you look at this structure, I can tell you, it's a structure that works this way, from one to many, many to one. From one to many, many to one. So this area here works like that way. So in a nutshell, in summary, or in a small amount of words, you can say any network, any brain network that you study, emotion, behavior, motor, sensory, whatever, vision, so at least one node must be arising from this area, at least one node. We're talking about node just now, right? The Kota Baru and KL, the area, the grey matter, the nucleus, and the highway, the white matter tract. Okay? So at least one node or one region, one area, one nuclei must be included in that network. So whatever network you say. So it seems that this area, therefore, is the vital area, is the important area, is at like one to many, many to one. So all the sensory area, all the input from the universe, from the cosmology, everything from outside you is going to this area, to the central deep part of your brain. Everything assembled there. From many going to one area. And from that one area is spread to the whole cortex or some other cortex. So it's spread. So it's, what I'm trying to say is diverge, right? From one and then diverge. Okay, initially from outside is converge and then it's diverge. So where is the converge and diverge side? You call it the point. So where is that point? the deep area of the brain. That's interesting. The deep area of the brain. So when you study this deep area of the brain, they are all important structure. Thalamus, hypothalamus, brainstem, pineal gland, pituitary gland, amygdala, hippocampus, everything there. All this structure. So when you study them, their function, everything. Memory, awake, sleep, breathing, the brainstem breathing, heart rate, everything. So automatic control, everything in there. So the scientists named this area as the greater limbic system. If you study the anatomy book, the old anatomy book, they call it limbic structure to do with behavior. The limbic network, the pipette circuit, the pipette circuit behavior consists of the cingulate gyrus, the hippocampus, the amygdala, the mammillary bodies, part of the thalamus, this pipette circuit. And then they expand it further. They expand the limbic to the emotional network or emotional area. So they cover the frontal lobe, the cingulate gyrus. And then lately, they expand it further to the greater limbic system. So all those covering the frontal lobe that deal with behavior, the midline structure, the cingulate gyrus, the brainstem, the hypothalamus, thalamus, now everything named as greater limbic system. Okay, so basically you can refer it as the deep and central part of the brain, which is in bending posture. Okay, so this interestingly also to note that this deep bending area is the one that gives rise to your brainwave. The study done, only one study so far, long time ago, 1949, shows that the brainwave coming from that area, but people still debate it. But that's the study done before. Show if you cut the fibers below here, if you cut the fiber above here, then the waves change. So from the conclusion, they say the brainwave coming from the deep central part of the brain. So, but some disagree, some agree. So the debate still going on. So, but I personally believe that the brainwave coming from that deep central part of the brain. So if you put the electrode inside there, the brainwave, they are very high energy wave. They are beyond beta. They are above beta wave. So the wave with high frequency. If you look at the Parkinson patient, they put the electrode inside there to stimulate, to reduce the tremor. So when they record the brainwave, the wave are so high frequency. The brainwave, if I want to summarize to you, you have slow wave, delta, theta wave. Okay, that one you call it slow wave, delta and theta wave. So that's happen when you get sleep, when you're going to sleep. Initially, you have high energy wave. So what those high energies? The alpha, beta. So now you awaken, you listen to my talk. So you have alpha wave mainly at the midline in the hospital. If you look at the computer, your hospital look highlighted, then you have alpha wave there. And if you're thinking, you start thinking your beta wave appear more in the frontal lobe. Probably in the parietal lobe if you do calculation. But when you get to sleep, the waves change gradually to the delta and theta. Okay, so you have delta, the lowest, theta, and then you have alpha, and then you have beta. And above beta, people call it lambda. And above lambda, even they call it gamma and so on. Okay, so this deep structure of the brain, they have higher frequency, probably lambda and gamma wave inside there. Okay. So the study done, probably I got it here, the slide here show that the study done, here the study done shows that the central part of the brain is the origin of the brainwave. And the brainwave coming, interestingly to note that they can be divided into two pathways. The thalamic pathway and the extrathalamic pathway. So what consists of extrathalamic pathway is the hippocampus pathway. So the energy or the brainwave or the frequency or the vibration coming from below brainstem is travel through the hypothalamus, and from the hypothalamus it goes to the hippocampus amygdala. There's a connection there to go lateral. From midline to lateral, there's a connection. I show it probably here. The picture here. So you see this is the amygdala, and here the hippocampus. There's a connection from the amygdala hippocampus to the hypothalamus. Here the hypothalamus. So hypothalamus connect with the hippocampus. Hippocampus connect with the hypothalamus. So basically what I'm trying to say, lateral also connect with the medial. The outer also connect with the inner for the deep structure of the brain. So go back to the origin of the brainwave. The brainwave origin can be divided into two. Again, duality. Again, male and female, day and night, poor and rich, short and tall, whatever you want to say, always two. You won't get one. Okay? That's the purpose of living anyway, to recognize a duality. So this thalamic pathway, this extra-thalamic pathway, one, we call it the dorsal one, behind, is a thalamic pathway. So the brainwave, the energy going to the thalamus and the spread, diverge to the cortex. As I said before, converge, diverge. From the cosmos, converge, the deep part, and then diverge. For the extra-thalamic pathway, same thing happened. So, converge and diverge. Okay? So, the input coming from outside, and then you go to the cortex. And from cortex, again, it's converge again. Maybe it's converge to the thalamus again, or converge to the hippocampus again. So that's why you see the memory consolidation is a converging effect. From the cortex, from your input, auditory, visual, so it's converged to the hippocampus. So the concept of diverging, converging, very important in the brain. Okay? So integration, diverging, converging. So that's why memory, you have vast memory in the cortex, and then it's converged into the hippocampus to store it there, to get it stored there. So converge there. Okay? Once you converge, store there, and then probably it diffuse again, diverge again to the cortex for long-term memory. So that's the theory behind it. But what I'm trying to say is the principle inside the brain seems to be so. There's a converging, diverging. Okay? And interesting to note is the cosmology, the converging, diverging part happen at the center part of the brain. And this converging, diverging can be two ways. A direction, B direction, or B direction, A direction. So it can be always two ways. Between area A and area B, always can be two ways. Bilateral connection. So that's the brainwave, okay? So why talking about wave is important? Because for you nowadays, for cognitive psychology, for the neurologists now, they even do EEG. The old days, they just talking the history, just talk to the patient. But nowadays, they buy the EEG, get the EEG and put on the brain and study the wave. And from there, they try to correlate with the symptom, sign, with the description of the patient. So this wave or EEG wave is energy because it's up and down. So people divide the energy according to the patterns. So those patterns according to the wave pattern. You have alpha wave, beta wave. Basically, it's a division of energy. Okay? So the beta alpha is a high energy because high frequency. And the delta alpha, even though it has high amplitude also high energy, but they have low frequency. So they are lower energy. So the energy in the wave, you can divide into high energy and low energy. So the characters of the high energy, normally they have high amplitude. Okay, high amplitude. So if you go to the beach, you see the tsunami. Tsunami has high amplitude. That's high energy. And then another one is the frequency. If too frequent, that means high energy. Okay, so both, if you have high amplitude and high frequency, that's very disastrous, very dangerous. But if you have high amplitude but not in terms of frequency, probably not that too dangerous. Okay. And interestingly, about the wave for EEG wave, you measure the area of the certain brain that cover probably for 60,000 neurons. So it's not one, the effect of the 60,000 neurons. So basically what I'm trying to say, the EEG is a superposition. So the information of the area of the nerve is a superimposed. So then you have that over sum or the total effect of those 60,000 neurons or 40,000 synapses in one electrode. Okay? So what I'm trying to say is...
Prof?
Yeah. Yes.
Prof, I just want to ask about those clients who have autism and ADHD. Is that their wave for theta and delta is too high, and then they are unconscious with the environment.
So this pathology or diseases depend on certain things. So you have to look at one, the anatomy. So the wave coming from this area may be different or altered or impaired in ADHD. So the wave, for example, the wave that measure at the hippocampus, so maybe impaired, lower energy. Or if you in Alzheimer disease, the frontal lobe electrode may be lower amplitude. So it depends on the anatomy, the area again, and also the wave, the energy, whether it's a low or impact energy. So always consider two, the anatomy, the area, and the energy. Always two. Okay, if you measure in the occipital lobe for the autism, maybe normal. For the early stage. So if you measure the electrode at the parietal lobe for the Alzheimer disease, maybe normal. So again, depend on the site. Okay. So it depends on the site. So the site, that's why when you're talking about site, you have to know the network. Okay. When you're talking about site, it's a network. So the network for the memory, short-term memory is from A to B, B to C, C to D. So you have to know the network. So network basically the anatomical connection, the site. So you have to know that network. So nowadays, everybody talking about brain network. So network for vision is like this. Network for hearing is like this. Network for movement, for thinking, for judgment, for happiness, depression, like this. Okay. So talking about network area. So when you measure the energy in that network, they impact. For the early stage, maybe one area impact, one not impact. For the chronic stage or medium stage, more impact. So because of that, they want to do EEG in all these patients, or psychiatric patient, or cognitive impact patient, EEG. Why EEG? Because they measure energy. Back to the energy. Life is energy, energy is life. So you can get more information. Okay,
Professor, can I ask one question regarding the children? I mean, those are under 3 years old because their amygdala is not developed the same way as adult brain. So how their brain waves, how they are when it comes to emotions and all these areas, how they are interacting with everything.
Okay, so my lecture will cover that. My lecture cover a bit on it. So the brainwave for the neonate and baby and young, they are different. They're having more slow wave. They have more sleeping time. So they have more slow wave. So their cognition also at the lower level. So if you ask the boy to cross the road, their cognition is not like adult. So they cannot judge. The frontal lobe wave is not same as the adult. So they cannot judge how fast the car. So because of that, energy inside the brain is different.
Yes, I can see that. But what I'm asking also, the when it comes to emotions, they are much more. My observation, of course, is the more capable of to showing feelings is maybe not the intellectual way as adults, but they look like their energy is showing more limbic system. All the areas we talk about right now is much more effective and more clear compared with adults.
Yeah, good point. So probably so. Their limbic network maybe better during that time. I don't know. So they have more bonding with the mother. So the bonding, the crying. So all this network, the crying network in the baby may be different. So probably so. You are right. Probably the network for that certain thing, they are better in the baby compared to adult. So when you grow up, when you get adult, the network become reduced. It can happen. Just like certain thing for the frontal lobe. When you were young, your primitive reflex is still present when you were newborn, 1 year old, 2 year old. That means suckling reflex, suckling. When you put the finger into the mouth, then you tend to suck. But when you get all the frontal lobe, inhibit that network. So that network become less or disappear. So probably same with your question. The network for certain thing maybe appear better in during that age. And then once the frontal lobe or the other area become mature, they inhibit that network.
I
Yeah.
see.
Yeah.
Thank
Okay. Okay, so this summarize my lecture for the one I mentioned to you. Basically, you can see as the center part is the director, and the rest are the plan is a CEO, is an input, this is a duo, and so on. Cerebellum, coordinating, balance, and accuracy. Okay, so this is just a summary. So talking about the wave. Before that, I missed something. Anything? Probably not. So we go there. There. Okay. Okay, wave, talking about brain wave, EEG is very important. I'm talking about quantum physics a bit for you all because it's interesting. So this is a fundamental level. You can see human as human body, or you can see as them as wave, or you can see them all of them as light, everything light. And the EEG, you can see here the type of brainwave. You have beta. This one I told you already, different type of energy, and people classify accordingly. And this the EEG. You have blue and red. The blue one's the even number on the right. Normally the even number blue. Normally the color blue is the standard color. The blue right is on the right side. The red odd number is on the left side. The right one odd number on the left side. So if you look at the EEG, normally color that way. For those who are not knowing, probably they just jumping over. They just mix up. But the best, the standard way is always like that. The red on the left, the blue on the right, the even on the right, the odd on the left. Okay, the midline is black and green. Okay, so you look here at the EEG. What I'm trying to say, the FP1, frontal polar, the F7, F3, F4, F8, FP4, they monitor the energy at the frontal lobe, okay, right and left frontal lobe. And the temporal T3, T4, the energy monitor T6, T5 as well in the temporal lobe. The C4, C3 make motor cortex. The P3 or P4 or maybe a bit of T6 cover the parietal lobe. O1, O2 occipital lobe. But some of them they are overlapping. For example, here the F8, F7. Even though the name's frontal, but they best monitor the energy in the temporal lobe. Okay, the F8 and F7. Even though the name is from the frontal, but the energy coming most from the temporal lobe. Okay, if you look at epilepsy, patient with epilepsy, sometimes the spike coming from the F7, and we know that the spike coming from the left temporal lobe. Okay, because of the name.
Doctor, Prof, sorry. Can I know FZ and PZ is the site for what location? Locate for what area?
Midline. The frontal Z, frontal midline, central Z, CZ for central midline, for PZ posterior midline, and the G ground is ground for grounding. M1, M2, some people use for reference. Okay.
M1, M2 is we put the electrode on the ear. Is it correct?
Yeah, some people put it there as reference. Some people even use the ground, the one as the reference. So it depends on your technologies. So sometimes the reference they put as the ground. So they can change around the ground. Or the reference. They can always change the ground. Or they can always change the reference. Sometimes the ground and different they put the two at the same time. Okay.
Okay, thank you, Prof.
So this is an MEG higher than EEG. We do have this, but then the machine is not working. So the MEG, you see the wave here, very high frequency wave. So talking about this already, talking about the deep structure and the high energy wave at the center. And if you haven't seen the structure inside the brain, this is the structure here. This is your pituitary gland. This is your pituitary gland. And this is your aqueduct, the tectum, and the brainstem. Okay, this is a blood vessel inside the brain. This picture here is showing the bending. The bending happened even during the formation of the CNS. The CNS always require buoyancy from the formation, early formation. Always require buoyancy. Buoyancy initially is provided by the pregnant uterus. This talking about one to many, many to one, again, same concept. And now, this one I'm talking about the connection. Okay, limbic mentioned to you already. It's talking about one to many, many to one. Even the amygdala, they have concept diverge and converge. From the nuclei, diverge and converge. But what you see most in the conscious patient, when you are conscious, the brainwaves are smooth, are synchronized, in coherence. They are not in chaotic. If you are ill, not well, your brainwaves are more like chaotic wave. This more like coherence, symmetrical or coherent, healthy like wave. So that suggests something to do with quantum physics. So talking about the deep structure of the brain just now, the greater limbic system, but you have to know about this subcomponent or area of the greater limbic system that play a big role. Talking about the RAS and RIS. RAS basically is we call it for the reticular activating system. Reticular activating system. Reticular refers to the structure inside the brainstem, the mosaic light inside the brainstem. The longitudinal structure from the medulla up to the pons and midbrain and project to the thalamus and even to the hypothalamus. So RAS and RIS. So RAS stimulatory, RIS inhibitory. Okay. So what consists of the RAS? They consist of the PPN, the pendicular pontine, the locus coeruleus, the raphe nucleus. If you heard this word, this location, they are very deep-seated location. So they are here, the picture here, inside the brainstem. RN, PPN, LC, locus coeruleus, RN, what's this RN? The raphe nucleus. Raphe nucleus, what's the PPN? PPN is the pendicular pontine nucleus, all inside the brainstem. Even some other nucleus as well. Very, very deep, detailed, small nuclei. So all this nuclei seems to be very interesting, very important. Okay. So this RAS projecting to the thalamus or hypothalamus. So they have excitatory and inhibitory. Okay. So basically they have two networks, thalamus and hypothalamic network. Same as I said before, the origin of the brainwave. It looks like nearly the same. And origin of the brainwave. And what are the chemical inside them? Deal with their network. Acetylcholine, serotonin, adrenaline, noradrenaline, and then amino acid, GABA, glutamate, everything in there. So the network that's been studied shows like this: dopamine mainly in the nucleus accumbens, mainly in the prefrontal cortex, mainly in the caudate nucleus epithelium, substantia nigra, and acetylcholine mainly in the septal nuclei, nucleus basalis. So it has rules, it has a principle that you have to follow. A certain area has this more than that, and in other area it has that more than this. Okay, so this is no adrenaline, this is a serotonin network. Okay, so you have to remember by heart probably. The hypothalamus, amygdala, hippocampus, locus coeruleus for the no adrenaline. Okay, so some excitatory, some inhibitory. So always two. Same with the sleep, waking sleep. Because it's close to the consciousness. So this two structure also deal with sleep, wake, sleep. Okay. So that's the debate. How to define consciousness? Is it part of the sleep? When you sleep, you don't have consciousness. That's the debate. Okay. Because apparently it seems that the waking sleep cycle also the area that deal with it also in that same area as consciousness. Okay, looking at the sleep patterns or cycle, talking about move to the sleep now. You have stage 1, stage 2, stage 3, and stage 4 sometimes, and then REM sleep. So some people call it divide to stage 4. Yeah, because some significant changes also happen at that stage. But the simpler one, you have stage 1, stage 2, and stage 3, and then REM sleep. Okay, so this is the division of the sleep. So the stage 1 is a light. You just going. You just feel like drowsy. And stage 2, you are more stable, going to sleep, going deeper. And stage 3, the deep one, your growth hormone being secreted and so on. So looking at this, that's why healing. When you are ill, you have to have adequate sleep because sleep is like healing, healing for you. You heal a lot when you sleep. Okay. Same when you sleep, it's consolidate memory. So make sure your kids have enough sleep. Okay. And when you play with the computer, with the handphone, make sure not much light to your brain because you need sleep. Okay. So if you don't have sleep, then you have altered brain function, altered blah blah blah. Then you have Alzheimer, you have dementia, and so on. Make sure you have adequate sleep. Okay. As I said, sleep very important for healing. Go back to the REM sleep. Stage 1, stage 2, stage and stage REM sleep. Rapid eye movement sleep. This is the time that most of you have dreams, rapid eye sleep, rapid eye movement sleep, REM sleep, and where the dreaming happens. Okay, so when you study this stage, you can see that the changes in the brainwave from the high energy to the lower wave. And then interestingly, when to the stage 2, you have another features on the EEG. You have K complex here. The K complex. It's like is it like K? So like no K alphabet. So K complex and slit spindle is a slit spindle. Slit spindle, if you're not careful, it can happen in artifacts, muscle movement, jaw movement. But if you measure the brainwave direct on the brain cortex, if you open the skull and you study it, then it appears that slit spindle happened in stage 2. Okay, stage 2 sleep. It happened in the EEG, but it's not easy because it can be artifact. But anyway, the point I want to say here, K complex and slit spindle happen in stage 2 of the sleep. Okay. This is stage. Stage 1, you like drowsy, your wave high energy to the lower wave. Stage 2, still got some energy there, but it appear K complex spindle start to appear. Stage 3 to stage 4, your energy is lower down. You're going to the delta theta wave. Delta theta 2 to 5 hertz frequency. You know the hertz frequency? The 1, 2, 3, 4 in 1 second. Then you have a 4 hertz. Counted the time. The time from X is the time. The Y is the amplitude. So how many in 1 second? So if this one you have 3 loops, 3 up and down, we call it 3 hertz. Okay. Like here, stage 2, you have many hertz, so it's alpha, beta. You have to count. But by looking at the appearance, you know by experience. Okay, so you see here a wave like this, and the deeper one you have more lower energy wave. But interestingly, when you get to REM sleep, rapid eye movement sleep, it's after stage 3 or after stage 4. When you are deep sleep, after deep sleep, then you have REM sleep, where the dreaming happened. Your brainwave, your energy is nearly same as when you are awake. So interesting. So it may be saying that dreamings try to tell something for you. The dreaming episode is trying to tell something about you, whether you are safe, you are truly safe or not. Okay, so the dreaming has important philosophical knowledge behind it, because the brainwave is nearly same as when you awake, when you're dreaming. Okay, so when you're dreaming, for example, you dream to London, you're going to London, but your body is still on the bed in Kota Baru, but you're dreaming you are in London. So philosophical, maybe, I don't know. Some people say your body is here, but your soul is in London. So everything is energy soul. So it means that they try to reflect the soul is not same as your body. Interesting. And the soul is the one that do everything. So you see here the brainwave for the REM. For the REM, you need to say same as the awake sleep. And you see the changes in the energy here, the alpha power, the theta delta power, when you do certain behavior, when you get deeper and deeper sleep. So you have more delta theta power. You study that. Okay. So the point I want to say that when you go to sleep, the energy coming down, but it's not flat. It's not totally flat. When you flat, you die. Okay. If the energy is totally flat or isoelectric, then you die. You call it brain death, or you dead. So death can be divided into two: brain death and cardiac death, or layman death. That means the heart and the lungs not working. Then you have layman death or cardiac death or cardiocirculatory death. But when your brain is not working, for example, important one is the deep part of the brain. It's not working. The greater limbic system, the one that caused the origin of the brainwave, and the brainwave become flattened, isolated, electric, and the test on the brainstem function is all gone, absent. That means you can say this man has brain death. So, two type of death, cardiocirculatory death or layman death. Orang biasa panggil layman death, or brain death. Okay, so two types of death, but anyway, they are death. Which one is more superior? Which one is more definitive? Brain death is more definitive. If you put the cardiac death person, the heart is not working, then you give medication, you put the ventilator, the lung breathing again. There's an up and down again. Heart rate appear, blood pressure appear, but the brain still isoelectric. So that means brain is superior than the heart. That means the ventilator, the medication can make the up and down appear again for the lung and the heart. But the medication and the ventilator or the machine or any human innovation cannot make the brainwave become up and down again after it flattened. After it becomes isoelectric, there's no human innovation can make the brainwave becoming up and down again. If you can make so, then you can make the dead become alive again. That's another interesting part. Okay, so how to make the flattened isolated electric become up and down? Oh, that's very interesting. If you can do that, then you can make the human alive again. When you put under general anesthesia, when you sleep, then the wave become nearly flattened, not flattened, but nearly flattened. When you're dead, only flattened. When you are having meditation, the meditation wave, the brainwave EEG wave is going down to the lower energy, delta theta wave, your meditation. But some meditation, the wave is going outward, it's opposite. It's going to the lambda and gamma wave. So you have two opposite waves, one down, one up. Why so? Then you have to come come and see me. I explain about the quantum physics because of the one field. So when you shift, you can shift either downward or you can shift either upward to get to that one field. Confused? Okay. So if you die, you tend to go downward. Your brainwave is going to the lower energy delta theta and a flattened isoelectric wave. But if you're going upward, it's not easy. You're going outward to the gamma lambda wave is not easy. If you can maintain, then you have meditation only, but you cannot go up further. If you can go up further and further, then you can see other dimension. Talking about other dimension, you know why? Since I'm talking to you about all wave, why all these waves are not clashing each other? Since everything are wave, okay, the whole cosmology covered by wave, why they not clashing each other? You know why? Hello? Hello?
Yes.
Yeah, okay, you listen to me, okay? So anybody thinking why all these waves not clash to each other? Because all our wave, the electric wave, the handphone wave, the TV wave, the tablet wave, your human wave, why do wave not clash each other? That's interesting. Okay, anyway, go to this one first. When you do or look at the sleep pattern, you have awake and non-rapid eye movement and rapid eye movement. So this is the behavior and physiology. So the eyelid become like this, the level of consciousness is like this, and the heart rate become like this, and then you can study on your own. Okay, the REM sleep, wakefulness, so they have changes in the physiological parameters as well. Okay, so this is a sleep cycle. You have many cycles in one sleep. You sleep a whole night from 11 o'clock to 6 o'clock in the morning, and then your cycle, probably you have 4 or 5 sleep cycle during your sleep that time. Okay, so one cycle maybe 1.5 hours. So that one cycle consists of stage 1, stage 2, stage 3, and REM sleep. Okay, so you have many cycles. Probably the baby don't have that many, or they have longer in stage 1, or they have longer in stage 3. It depends on your age. So this again the sleep cycle. This is the importance of the sleep, and this is the age. When you are sleeping in newborn, you have average amount of sleep up to 18 hours, and when you are getting older, then you have the hours reduced. If you sleep too much, then it's not good as well. If you sleep too much, then something to do with the chemical, with the blood flow. When you are lying down flat, then the brain also. Hold on. Hello. Yes. Yeah. You see that when you get older, less hours. But if you sleep more when you get older, then your brain also not good. You have more blood supply. You tend to have headache. You tend to have headache because of increased blood supply to your brain. It's not good. Too much blood supply, it can cause headache. Too much sleeping when you get older, you can have headache. Okay, this is important of the sleep. If not enough sleep, for example, patient with sleep apnea or tongue falling backward, not much oxygen to the brain, then you have Alzheimer later on, develop Alzheimer. This is important of the sleep. Show the importance of the sleep again. Okay, basically talking about consciousness and sleep today. So basically when you look at it, it has two components, arousal and awareness. I mentioned to you before, arousal and awareness. So this is a summary of the conscious imaging. It's a conscious patient, it's a PET scan. And this is a vegetative patient like this. It's a minimally conscious state. So this is a summary for a different state of patient in conscious impairment. So you have a lock-in syndrome, you have minimally conscious state, you have vegetative state, you have coma patient. Coma is like this. The level of consciousness order is low and the content of consciousness or awareness is low. Okay. For those with a vegetative, it's like this. You have higher consciousness, but you have lower awareness. Lock-in syndrome, you have both higher, but you cannot respond. Okay. So this is a summary for the normal consciousness. Your arousal like this, your awareness like this. Your coma, you have low for both, but vegetative is like this, and blah 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 blah. Okay. Lock-in syndrome is like that. You have both high, but you still cannot respond to the external, to the people around you. We call it lock-in syndrome. The pathology or the disease at the brain, at the midbrain. Okay. So different type of disease or impairment in consciousness. This is just revision from study. Now they show different things about consciousness. And attention system is also important. You have to be conscious to have attention. So where's the attention system? So when you discuss about attention, so maybe you need to discuss a bit of consciousness as well. So the attention system is closely related to the consciousness. So you have people divide into anterior attention system and posterior attention system. So you have prefrontal cortex, you have anterior cingulate cortex, that's again there for the anterior one. For the posterior one, you have parietal, thalamus, cerebellum. So this is just only a network, the anatomy. So the proof, the evidence say like so. The attention system involves this structure. So patients with ADHD, autism, schizophrenia, psychosis, they have impairment in attention system. So maybe the prefrontal cortex impact, the anatomy there is impact, the chemical there is impact, the energy there is impact. Or maybe in other patients with slightly different degree of severity, the parietal lobe and the anterior cingulate cortex is impact. Or in another patient, the whole area impact. The chemical, the energy, everything impact. So you see, first network, anatomy. Second, the energy. Okay, the wave. Okay, so I think that's the end of my lecture for both. Before I go, probably, just want to remind you all, we have second lecture, right? 27 January, right? And 27 November, right? Hello? Hello? 22nd November, we have a lecture again. So I'm going to give lecture on 29 November, lecture on memory, psychosis, and a bit more. Probably I talk about imaging a bit for you. And then the last one in January 2021, that one will be on Saturday, 5 to 7 seminar. So seminar, probably you all present to me. So probably who gonna present it on limbic system on where was it? On 16 January. So the 16 January is not me to present to you, but you present to me. So who want to present the limbic one? So you all present the limbic. So probably two of you present the limbic system. Who volunteer to present it?
Okay. Prof, I think we already divided among us, and then each group have about group members, like 5 to 6 group members, and one of the group already took limbic system.
Okay, you can present to me on that day lah, so I can add on more on that. So you all can present on that day. Probably it's more like revision. The January one is more like revision. Okay, so you can you decide among yourself, and then probably one or two present on name basis on that day. So, and then probably I can add on something on that day, 16 January. So probably the 16 January we finish early. Okay. Any question? Any question so far? Consciousness is very interesting, very complex, and it's not just only medicines cover quantum physics. Anything?